Hello, I'm Dr. Anthony Wheeler, and I'm telling you everything that you need to know about pathology. Now, what's going on in this image? Do you recognize this physical exam finding? I sure hope so, because this is classic. We're going to be discussing thyroid gland pathology. This is covered in your book, Medical School Pathology and Step 1 Review. You can scan the QR code to get to the updated material. Thyroid gland pathology is extensive, and we're going to be covering the very important things that you must know. Starting with thyroglossal duct cyst, which is a cystic dilation of the thyroglossal duct remnant, as you can see here on an ultrasound. The thyroglossal duct leads from the base of the tongue to the anterior neck, where the thyroid develops. While the thyroglossal duct ordinarily involutes, a prolonged duct may enlarge cystically. Thyroglossal duct cysts present as an anterior neck mass. And while we're talking about anterior neck mass, you should have some differential that you think of when you think of anterior neck mass, right? Not only a thyroglossal duct cyst, but some sort of thyroid malignancy, as well as a thymoma, a lymphoma, and teratoma, okay? So here we have the thyroglossal duct cyst with papillary excrescences. Interesting. And this patient had a removal of a thyroglossal duct cyst. A surgeon, probably you in the future, may be performing this. And here we have another patient. On physical exam, she has a clear protuberance on her anterior neck, which was found to be a thyroglossal duct cyst. And here we have a histology of a papillary carcinoma that was within a thyroglossal duct cyst. Note the papilla present. And here we have a papillary carcinoma that was in a thyroglossal duct cyst. So now let's talk a bit about a lingual thyroid. The presence of thyroid tissue at the base of the tongue is known as a lingual thyroid, okay? Lingual thyroid appears as a mass at the base of the tongue. And here we have imaging showcasing thyroidal tissue at the base of the tongue. And hyperthyroidism, this is something that you will see a lot. When the thyroid gland overproduces the hormone thyroxine, hyperthyroidism, or an overactive thyroid, may occur. As in the case of Graves' disease, as we can see here on the histology, showcasing diffuse hyperplasia of the thyroid gland, clinically presenting as hyperthyroidism. Now, what are some features of hyperthyroidism? Maybe sweating, hyperactivity, can't keep weight on, feeling hot, things like that. You can think of it as the metabolic system being revved up. Hyperthyroidism causes an increase in sympathetic nervous system activity and a rise in basal metabolic rate as a result of increased sodium potassium ATPase production and beta-1 adrenergic receptor expression, respectively. Now, some symptoms, as you know, of hyperthyroidism include weight loss despite an increased appetite. That's right, they're eating, ordering all sorts of goodies. Heat intolerance, right? That just means they're hot. And sweating, which makes sense. Tachycardia, tremors, and anxiety. Here we see a histopathological image showing diffuse hyperplasia of the thyroid gland that clinically presented as hyperthyroidism. Note the focal papillary hyperplasia of the follicular epithelium. And here we have another histopathologic image showing diffuse hyperplasia of the thyroid gland, clinically presenting as hyperthyroidism. And again, now in this image, we have anti-CD31 immunohistochemical staining in a control group as well as in a hyperthyroidism group. Note that this is trying to showcase there's an increased density of vessels with the hyperthyroid group, right? And here we have imaging showcasing a papillary thyroid cancer presenting with hyperthyroidism in a 12-year-old female. Now that's very young. Typically you will see these in young adults or older. 12 years old, that's very early. And here we have stained dermis and epidermis by IHC in a hyperthyroid group as well as in the control group, noting the effect of maternal thyroid disorders during pregnancy and lactation on skin development in rats. This is for my MD PhDs out there. I haven't forgot about you. So now let's talk about a condition that's very important to know. You will see this a lot, no matter what you go into. Graves' disease. Graves' disease is an autoimmune disorder that affects the thyroid. To the right here, you can see a scan of an affected thyroid before on top and after on the bottom. Radioiodine therapy. You see how hot it is up top? In Graves' disease, autoantibody IgG activates the thyroid, stimulating hormone TSH receptor, which increases thyroid hormone production and release. In women of childbearing age, Graves' disease is the most common cause of hyperthyroidism. And since it's the most common cause, guess who's going to have to know it? Every single one of us. Hyperthyroidism, diffuse goiter, and persistent thyroid stimulating hormone stimulation cause thyroid hyperplasia and hypertrophy as clinical characteristics. Now, what are some features of Graves' disease clinically? Well, as you've seen, no pun intended, exophthalmos, also known as proptosis, right, when the eyeballs are protruding forward out of the skull, right, as well as pretibial myxedema. You may also see that clinically. Thyroid stimulating hormone activation causes glycosaminoglycan buildup, including chondroitin sulfate and hyaluronic acid, as well as inflammation, fibrosis, and edema, which result in exophthalmos and pretibial myxedema. It's really interesting how this occurs. The fibroblasts behind the orbit and atop the shin express the thyroid stimulating hormone receptor. Now here we have the histology of Graves' disease, showing irregular follicles with scalloped colloids and chronic inflammation. Now you can't really see the chronic inflammation here, but I'll be sure to point it out for you. Laboratory findings of Graves' disease show increased total and free T4, decreased thyroid stimulating hormone, even hypocholesterolemia, right? Cholesterol's low, hypocholesterolemia, and elevated blood glucose, right? Free T4 down-regulates thyrotropin releasing hormone, TRH, receptors in the anterior pituitary to reduce thyroid stimulating hormone release. That's important. That ties into physiology of endocrinology, so you'll probably see that somewhere. And the treatment of Graves' disease includes thiamide and radioiodine ablation. Thyroid storm is a potentially fatal condition caused by huge hormone excess and high catecholamines, which are typically produced in reaction to stressors like surgery or delivery. The symptoms of thyroid storm include hypovolemic shock, tachycardia, heat intolerance, and vomiting. Beta blockers, you're going to have to know that. Beta blockers, steroids, and PTU, which is for propylthiouracil, are potential treatment options for Graves' disease. Propylthiouracil prevents peripheral T4 to T3 conversion, as well as the peroxidase-mediated oxidation, organification, and coupling phases of thyroid hormone production. Here we have a cartoon showcasing many features clinically for Graves' disease. You may have a patient with fine hair, exophthalmos, like what you've classically seen, enlarged thyroid because of the goiter. They may be sweating, have a high, fast, rapid heartbeat, lose weight even though they're eating more, have muscle wasting, even tremors, and in females, oligomenorrhea. You recognize this. We don't even need to talk about exophthalmos because this image is what keeps you up at night. Okay, Graves' disease, histology. Okay. More Graves' disease histology. Note the nodular hyperplasia of the thyroid, secondary to patient with Graves' disease, demonstrating abundant follicular structures with scant colloid, and that's an A. Always have melanoma on your differentials, right? In real life, it shows up. It's called the great mimicker for many reasons. Now let's talk about multinodular goiter in more detail. A multinodular goiter is described as numerous nodules and an enlarged thyroid gland caused by a relative iodine deficit. To the right here, we can see a representative scan of a multinodular goiter. Note that this goiter had toxic adenoma, which it was lighting up. Multinodular goiters are typically non-toxic. They are euthyroid. Rarely, an area will lose its thyroid stimulating hormone dependent state, causing T1 release, hyperthyroidism, or toxic goiter. Here we have a patient from a long time ago out in the Western Plains that had a multinodular goiter. And again, a more recent image of a patient with a multinodular goiter. And this is what it looks like grossly. By grossly, I mean after a surgery has occurred and a thyroid is removed. But this may actually be from a cadaver because typically when the thyroid is removed, we leave the trachea for you future surgeons out there. Now, here's what multinodular goiter looks like histologically. To the left here in panel A, we can see a photomicrograph of multinodular goiter. And in B, we have the multinodular goiter that's negative for cytokeratin 19. But what I want you to appreciate is all the various thyroid glands that are enlarged, filled with colloid. So now let's switch gears here and talk about hypothyroidism, right? Low, hypo. Woo! Cretinism. Hypothyroidism in newborns may result in cretinism. What are some symptoms of cretinism? Well, mental retardation, oversized tongue, small stature, macroglossia, which is just another way of saying enlarged tongue, skeletal deformities, and coarse facial characteristics. Thyroid hormone is required for normal brain and skeletal development. And cretinism may be caused by conditions that inhibit that, such as maternal hypothyroidism during early pregnancy, thyroid agenesis, dyshomogenetic goiter, and iodine deficiency. And what about myxedema? Well, older children or adults with myxedema have hypothyroidism, which is characterized by a decline in basal metabolic rate and a reduction in sympathetic nervous system activity. Myxedema is the accumulation of glycosaminoglycans in the skin and soft tissue, which causes weight gain despite a normal appetite and a slowing of mental activity. Myxedema also causes a deepening of voice and tongue enlargement. Myxedema also results in muscle weakness, cold insensitivity with decreased sweating, bradycardia with decreased cardiac output, a feeling of weariness, oligomenorrhea in females, hypercholesterolemia, right? Hypercholesterolemia, and constipation. Some causes of myxedema include iodine deficiency, Hashimoto thyroiditis, lithium medication use, surgical removal of the thyroid, and radioactive ablation of the thyroid. And since we're on the topic, let's say your patient was using medication, a specific medication used to treat depression, right? Is that lithium? Does lithium treat depression, or is that something else? Let me know, you future psychiatrists out there, or psychologists. Myxedema. Here we have imaging showcasing a microscopic finding of the liver showing accumulation of yellow bile pigment in the hepatocytes, right? Now, thyroiditis. You know what that means. Thyroid, like the gland. Itis, like inflammation. Let's talk about it. Hashimoto thyroiditis. You definitely must be very familiar with this. Now, Hashimoto thyroiditis is the HLA-DRS related autoimmune destruction of the thyroid gland. Hashimoto thyroiditis is the most frequent reason for hypothyroidism in areas with sufficient iodine levels, i.e., Western civilization for the most part. The progression from hyperthyroidism to hypothyroidism may begin out as follicular damage-induced hyperthyroidism. The presence of antithyroglobulin and antimicrosomal antibodies is frequently indicative of thyroid impairment. Here we have the histology of Hashimoto thyroiditis. Now, you should be able to see discrete lymphoid follicle-like regions, right? Kind of looks like a lymph node to the right there. And to the left, clearly histology of a thyroid. Note the pools of colloid. You see all that basophilic deep blue areas, those are infiltrating lymphocytes. So histologically, Hashimoto thyroiditis shows chronic inflammation with germinal centers, and Hürther cells is associated with eosinophilic metaplasia of cells lining follicles. So keep that in mind. Now, there is an elevated risk for B-cell lymphoma in Hashimoto thyroiditis. And here we have more imaging showcasing a higher power view of the histology for Hashimoto thyroiditis. Now let's talk about something a bit different, right? Subacute granulomatous thyroiditis, eponymously known as the Quervain thyroiditis. Subacute granulomatous thyroiditis is due to a viral infection that actually manifests as a sensitive thyroid and temporary hyperthyroidism. To the right here, you can see the histology. Note the idiopathic granulomatous thyroiditis that is present. Subacute granulomatous thyroiditis, as you know, is called the Quervain thyroiditis. Okay? Subacute granulomatous thyroiditis is self-limited and does not progress to hypothyroidism. Now, there's a different condition that is lower yield, but you're shooting for the stars, so you want to know this. Riedel fibrosing thyroiditis. Riedel fibrosing thyroiditis manifests as hypothyroidism with a buzzword, hard as wood, non-tender thyroid gland, and is a chronic inflammation with significant thyroid fibrosis. Local structures like the airway may get affected by fibrosis that has spread. And clinically, Riedel fibrosing thyroiditis resembles anaplastic carcinoma, but the patients are younger and no malignant cells are present. And speaking of malignant cells, let's talk about thyroid neoplasia. But before we get to malignant, let's start here. Thyroid nodules are more likely to begin as benign than malignant, right? They're usually benign. And thyroid neoplasia usually appears as a distinct, singular, solitary nodule. I-131 radioactive uptake studies are useful to further characterize these nodules. Increased uptake is a hot nodule, and you can see that in Graves' disease or a nodular goiter. Decreased uptake or cold nodule is seen in adenoma and carcinoma, and they often warrant a biopsy. Biopsy is typically performed by fine needle aspiration. And since we're talking about this, if you see in a clinical vignette or in real life that an FNA didn't get any cells, you should move Riedel fibrosing thyroiditis up on your differential, as well as the Quervain's fibrosing thyroiditis, right? Especially the Quervain's, because that's very fibrotic and it's really hard to get things. Riedel's, you may see some giant cells if you're lucky. So thyroid neoplasia. To the right here we have a multinodular goiter, right? But on this we have a follicular thyroid adenoma, right? Follicular thyroid adenoma is characterized by a benign proliferation of follicles encased in an inactive fibrous capsule. Follicular thyroid adenoma does not invade the capsule. As you can see here, it's important to keep that in mind. You'll probably see something like that in the near future. So what we're looking at here is a surgical excision specimen of a thyroid that was bisected, or actually serially sectioned. And then when the nodule was found in a particular section, it was taken a photo of. And in this photo, what we're seeing is that this nodule in the upper right region is not going through the thyroid capsule, right? It's very well circumscribed. It's not breaking through the capsule. Follicular thyroid carcinoma, on the other hand, is the malignant proliferation of thyroid follicles with invasion through the capsule. Now, it's very important to make the distinction between this and an adenoma because, one, they have different prognosis, and two, you will be asked about it for sure. So to the right here, we can see histologic evidence that follicular thyroid carcinoma is breaking through the capsule. You see that right there? See it breaking through the capsule? Follicular thyroid carcinoma invades the capsule. And here we have some FNA showing a micrograph of a Hürthle cell neoplasm. But note, the distinction between a follicular adenoma and a follicular carcinoma cannot be made by a fine needle aspiration because an FNA only looks at the cells and not the entire capsule under a microscope, right? So you might see a trick question like that. Metastasis of papillary thyroid carcinoma generally occurs via hematogenous spread. And in regards of a papillary thyroid carcinoma, a PTC is the most common kind of thyroid cancer, right? It's very common. And a significant risk factor for papillary thyroid carcinoma is early ionizing radiation exposure. Histology of papillary thyroid carcinoma shows papillae that are lined by cells with orphan ani nuclei that are clear and nuclear grooves that are frequently found around samoma bodies. The prognosis of papillary thyroid carcinoma is excellent. The 10-year survival rate of papillary thyroid carcinoma is greater than 95%, despite the fact that this frequently spreads to cervical or neck lymph nodes. Here we have a micrograph of metastatic papillary thyroid carcinoma to a lymph node. Can you see the difference in features on the image to the right here? Can you see the metastasis? And can you see the normal lymph node architecture? And here we have a micrograph showing histopathologic image of papillary carcinoma of the thyroid gland that was obtained by a total thyroidectomy. And these arrows are pointing at the nuclear grooves, right? You classically see those. And here are different features of papillary thyroid carcinomas that you should be aware of, some more than others. You should definitely know what samoma bodies look like, as well as nuclear pseudo-inclusions and nuclear grooves. And here we have a micrograph of papillary thyroid carcinoma demonstrating the prominent papillae with fibrovascular cores. And here's what it looks like grossly. This is what appears to be an FNA, illustrative of features showcasing papillary carcinoma. There's nuclear grooves and pseudo-inclusions. Yes, this is a cytology specimen. And this is a follicular variant of papillary carcinoma of the thyroid gland and squamous carcinoma in close juxtaposition, right? You'll probably not see this on a test, but keep this in mind in real life. Always be looking for whatever is present, right? Because many conditions can show up with other conditions. It's not common, but it's frequent enough. Now let's switch gears and talk about medullary thyroid carcinoma. You're familiar with this. The malignant proliferation of parafollicular C cells, which makes up about 5% of thyroid carcinomas, is known as medullary thyroid carcinoma. Medullary thyroid carcinoma may result in high quantities of calcitonin and cause hypocalcemia. Histology of MTC, medullary thyroid carcinoma, reveals sheets of malignant cells in a calcitonin-derived amyloid stroma. So if you're asked, what is that amyloid stroma derived from? You know it's calcitonin. Multiple endocrine neoplasia, or MEN2A and 2B, which are linked to mutations in the RET oncogene, are often the cause of familial cases of medullary thyroid carcinoma. When the RET mutation is found, a prophylactic thyroidectomy is necessary. And here we have imaging via an ultrasound showcasing medullary thyroid carcinoma. And here we have medullary thyroid carcinoma histologically. And here we can see various thyroid carcinomas on the histology. I'd make myself familiar with that. But I want to highlight here that anaplastic thyroid carcinoma is a big deal, so you're going to need to know it. An undifferentiated malignant thyroid tumor called anaplastic carcinoma is typically detected in older people. And anaplastic carcinoma frequently infiltrates nearby structures, causing dysphagia and or respiratory problems, right? It's anaplastic thyroid carcinoma is a big deal. Anaplastic carcinoma has a poor prognosis. And with that, I conclude this presentation. You made it through one of the very important presentations. Some of the other ones weren't as important. This one's definitely important because there's a lot here, right? A lot of testable material, but I know you got this. I believe in you. Keep up the good work, and I'll see you later.